everyone. Welcome to our FEAR podcast. My name is Emeline, a master fellow of the program. We have our friends here, Dr. Lucas, Dr. Adriano, and Dr. Fred. We also have our professor, Dr. Flavio Rezende. And today we have a very special guest, Dr. Kapusta. Thank you for coming with us today.
My pleasure.
Dr. Kapusta is a great retina surgeon from Canada. He is professor at McGill University. And thank you for joining us today. Would you like to know more about your program of fellowship? What do you expect from international candidates and something like that?
It's great. Well, first of all, I'll start by saying how proud I am, as the name is Pierre is proud in French, to see this develop and the ongoing education of people in Brazil through a great Brazilian who's my neighbor here in Montreal. And I think it's testimony to not only my work, but others who've trained Flavio and who've trained and then propagate this knowledge from generation to generation. And I was the beneficiary of this. I trained I trained in LA at Doheny when it was part of the USC program. And among my mentors and a strong connection to Brazil is Lawrence Chong is the person most involved in my training. And my understanding is he still remains quite connected with the retina community in Brazil. Obviously, Dr. Rezende knows him well. And we can't even begin the conversation without understanding where it starts, who helped us to get to a point, and then where do we take it from there. And when I look at this, Fearcast, it's incredible, Flavio, that you continue to devote time and energy to travel and to improve the education, not just of their fellows down the street in Montreal at University of Montreal, where you are truly, the Brazilians use the word professor. Here we use it a little more tightly. Actually, I'm quite proud Flavio is truly a full professor of ophthalmology at the University of Montreal. And that's quite a distinction. You have to be academically proficient, acknowledged. You have to go through the rigors of a search that shows that you're qualified to be this. So the word professor to me is a little bit different. It doesn't mean someone who's knowing. That's fair. You could say that of a teacher and perhaps in university, but in medicine, a professor is someone in North America or in Canada for sure. A professor is someone who's met certain standards, has published to a certain extent, has published high quality in the right journals, has done it not just inconsistently, and has been acknowledged by his peers or her peers, and who's understood internationally and by many to have unique qualities. So Flavio has achieved that in the past calendar year, and it's one of the the word pride just keeps coming back, because we're going to talk about fellowship and what I think a fellowship entails and what the responsibilities of a fellowship are. But this is the perfect example. So I accepted this invitation, not necessarily knowing that this is where I wanted to go with it, but I think there's probably no better way to explain to younger people, like I said before we started the podcast, a generation that's young enough to be my kids, although my kids are much younger than you guys, that it's it's not necessarily the same everywhere in the world, but one thing seems clear to an older generation such as myself, that it's definitely diluted. The intensity is diluted, and that does not help you become great. So if I had one line to say from tonight, it's the diluted intensity of training produces good but not great physicians and retina specialists. By throwing yourself completely in with whatever tools you have, whatever skills, whatever coordination, whatever aptitude, knowledge, capacity to expand that knowledge, if you don't throw yourself in at this critical stage of your lives, you will not only come up short in your capacity in what you can offer, but you'll live with stress forever. You'll live with stress because you'll not know what's coming and whether the next case is going to be too much for you. So by doing something that I did, I literally, again, I come back to USC Doheny. And when I trained 2 years so intensely that when I finished in California, geographically, I moved across the country to Montreal. I started to set up an OR. There was no other retina surgeon at the facility that I work at. And until this day, 28 years later, there still is no other retina surgeon at the facility I work with. Fortunately, I'm going to be recruiting somebody this summer, but that's 28 years of quite intense one-on-one call kind of work. But when I finished my fellowship, I got the paperwork in order to practice. And then I flew back to California to see California, because when I was in training, I didn't have time to look at the beaches. I didn't have time to see the restaurants or the clubs in Los Angeles or Santa Monica, the promenade. I lived in an operating room for 2 years straight, day and night. And that's what made me able to do what I do and carry it forward every single day, month, year subsequent to that. And yes, I think there's time for rest and there's time to enjoy life. And there's more than just medicine for each of us, but not for the 24 months of a fellowship. That's when there's nothing else on your mind. There should be nothing else on your mind, because as I, have trained now over 25 people, those that have succeeded were those who didn't necessarily start with the most, but put in the most. So I'm going to tell me if I'm rambling on too much, if you want me to pause for a second, but I'm going to use you, Flavio, if you don't mind, as an example.
So yeah, that's I just want to interrupt a little bit, because I usually I usually make an introduction of each guest, and part of the reason why Fier is named Fier is because it's what I am from who trained me. You were the most influential person in my career. My father has had an early start, but in the retina world, you were by far the most influential person in my career. David Chow helped, put some, bells and whistles in my in my training, but the core, it came from you. And so my current and past fellows, sometimes they're gonna hear things from you that may sound like I'm talking to them, because that's where it came from. So yeah, so that is the one thing that I wanted to say, so you guys can relate to who Dr. Kapusta is. So and I think that you guys should ask all the questions that you can or can think of that could be helpful for fellows in training, fellows that just finished their fellowship, or the ones who wants to apply for fellowship. Because Kapusta is not only great surgeon, he can actually shapes up your mind, in the OR. And from the OR, this shape can actually improve you as a person, and you can carry on. I started my fellowship as a boy. I finished, I was a man. This was like in a 2-year process. And why? Because I was, what he said, 100% devoted. There was nothing else that was more important than this. Day, night, day, night, day, night. We operated so many nights in a row. So, there's no real secret in our profession. If you don't put the work, you don't get the juice.
So, maybe that's a perfect, thanks, Flavia. That's a perfect segue to give you an introduction. Okay. So if if you understand I talk about where Flavio is now, professor, and it wouldn't be an exaggeration to say, what have I accomplished in my career? Well, I've done a lot of good work in making other people, residents, students, medical students, but mostly fellows, understand how I feel, how responsible I feel, and how I think they should carry themselves with such responsibility to taking care of patients. It's not a volume, get them done. Every single person in your waiting room, that's the scariest thing of their day. And we may not have the time to fully support them emotionally in that, but if it's your macular hole, even though I did 4 macular holes, 3 of them were over 700 today with ILM flaps, it's just a technical thing. That's scary for that person. Second eye, 10 years later, that it's quite important. It's a privilege to do this. And I don't think anyone who trains with me, even though there's volume, thinks that I don't still respect the privilege that it is to be a physician and to be in ophthalmology, because there's so many who really want this very competitive field to get into. And then retina, even, it's the creme de la creme, we say in French, the cream of all of it. It's the most challenging work. I think it's widely accepted that is the most challenging work. And so, I started off out of that fellowship that I described to you before with Chong, and some of what Flavio is telling his fellows is really my words, but they're really Chong's words. So this just goes on and on, right? So, and that's, Makamer's words and Eugene Dewan, who trained Larry Chong. So, hypotony is your enemy. I didn't come up with that, Flav. that was that. I can still hear, Larry Chong's California accent saying that to me many, many times. Like, be careful with the infusion. First thing in, last thing out. Hypotony is your enemy, man. Come on, dude. Make sure that infusion's in the eye. So, that got propagated to you. But I left that fellowship and came back to Montreal. And as I described, I, socially wanted to see California. But once I got started, before I even had OR privileges, somebody walked up to me in the hall. I mean, I was in t-shirt and jeans and saying, yeah, I'm starting in a few months. And a glaucoma surgeon came up to me. He had trained me as a resident, the same facility. And he says, I got a guy with a lady with choroidal detachment. Those do pretty well, right? I said, well, some of them do well, some of them not quite so. And he goes, well, I think these pretty much do well, glaucoma doc. And he goes, could you take a look? I go, I'm in a white t-shirt here and jeans. He just, don't worry, he's got glaucoma. She won't, just come in. So I go in. The lady has.
You hadn't started your fellowship yet.
I had not. No practice.
Oh, practice.
I came back from the fellowship.
Coming back.
I hadn't started my practice. I didn't have an office. I didn't have a pad with a prescription pad. I had nothing. Okay. So, and I didn't have OR. Nothing. I didn't have OR privileges yet. But he asks me in the hall, and I said, okay, I'll take a look. The lady had, many weeks of sitting on, because nobody was in the institution, hemorrhagic, appositional choroidal detachment, shallow chamber, elevated pressure. And I said, well, this needs to be drained. Like, do we have an ultrasound here? I think there's an ultrasound in the corner over there. Yeah, imagine. Okay. And I'm like, well, we've got to do this. So that's
how, when you started, right?
I hadn't started. I was just walking in to say hello.
That's my first situation where you were going to start. So
exactly.
So they understand that you're not coming to a facility that had everything.
No. This is where not only was I planning to start. This was like the first few days of of my just getting oriented. Where am I going to get a prescription pad made? What's my billing number? Where am I going to do surgery? How many patients are we going to book in the who's going to be my secretary? This is a hallway near the bathroom. Where conversation from one of my previous teachers, now colleague, and me about a patient. And so this is what it takes to be a retina person. I looked at the eye. I said, it needs to be done. I called the sister hospital because they had an operating room. I got emergency privileges. I brought that patient to the OR that night. in the old classic, not Flavio Rezende invented, my pride, another pride, technique, the old technique where we loop the muscles, put the infusion line in the anterior chamber, all 20 gauge. This is a long time ago. Okay. There were no trocars. So go in, put the infusion, cut down like draining sclerobuccal with a 69 blade, drain the choroidal. And I had just written a chapter on choroidal detachment, by the way, in my fellowship, the first version. There's 4 since then in the Yanoff and Duker book. So I wrote a chapter, I just finished it, and I see that the retina is stuck together.
Oh.
Stuck. I look with an indirect. You guys, we didn't have such perfect wide angle viewing systems. I look with the indirect and go, oh, that retina is still stuck together. Well, I wrote about it, but I never saw one. Okay. And I'll share with you, I never saw, we discussed it, I read about it, but I never managed this.
And
I don't have.
There's some good people that believe that the retina doesn't stick together.
It does. But let me tell you something. That first case was the only time I've ever saw that. Day one. So I'm not exaggerating one step of this. I don't know what to do. I just put in a big 6 millimeter infusion. I do the vitrectomy as best I can. And I'm like, retina stuck. I know, I'll put perfluorocarbon behind, start putting perfluorocarbon, it opens up a little, but the retina is really stuck in the middle. Cautery, retinectomy on one side, cautery, retinectomy on the other, more perfluoro, laser both sides, air perfluoro, little bit of gas, 2025.
No.
You got to get lucky too, guys. You got to get lucky. You can't just be good. You got to get lucky. That glaucoma doctor says to me, I told you these do well.
So that's why you're still in the same hospital. 20, 80 years, no?
Well, you know what? That's a very good point. I mean, there's so much that we can talk about, and most of it I want to steer towards fellows. But as a faculty, I have been, I think, pretty good at doing the surgery, and I've had the responsibility of taking care of that kind of patient, but many community VIPs. Flavio understands the nature of where I am and the fact that I just don't have a choice. I mean, I've operated on my mother, I've operated on my sister, I've operated on uncles. It's just the way it was. It's not a pride thing. It's not a trying to do it. It's just, that's what comes to me. A prime minister, the head of the hospital, the guy whose named lecturer flew from on a jet back in Florida with endophthalmitis. They met him, the CEO of the hospital, at the operating room doors, wheeled him in. I mean, all of these are experiences. And I've been lucky enough that all those very important cases have turned out perfect. And that's given me a lot of influence in the institution and a lot of equipment so that I can help people day in, day out, because they're not always these kinds of cases. So it has not been used to my own advantage for name, reputation, or money, but I use those situations where the right results occurred to get more equipment to help more people. And, this is a bit of a struggle in our province, but I've been very fortunate they turned out that way. But let me turn the attention back to starting from fellowship. So that first case was one such example. Within that year, Dr. Chow joined, so 2 retina surgeons the same year, and we recruit our first fellow. You may have heard of him, André Maia de Carvalho. That's where we started. And it's, we liked Brazil so much after that, we had to have a little more. And that's when, I was introduced to Flavio. Actually, I think the first time was in Rio, right? Like I came down at Andre's request to talk or lecture at some meeting, and then I flew to meet you before the fellowship in Rio. Now, the professor was literally a boy, and obviously the aptitude and a boy, cute kid, very cute kid. But I said, okay. I mean, the ages were not so different. You realize when you start training people and you're fresh on staff, you're close in age to the fellows. Now I'm old enough to be their dad, but back then I was, I ended up becoming friends with all of them in the first 5 to 10 years because they were similar in age. I was quite young when I started my practice. So Flavio comes and is, again, that devotion, does research, reads papers, came up, right? You were doing that research period first.
I was doing my PhD at the same time.
Yeah, to get acclimatized also to the environment and be ready day one to, hit the ground, as we say, hit the ground running. But the first time I saw him put an indirect on his head, I said, oh my gosh, what did they hand me? What are yo, bro? How do you make these things work? And the light does. So this is not to diminish the training that, there's a diversity of training in any country, but it is, I believe, fair to say that there's a huge heterogeneity to the consistency of the programs that I learned in Brazil. Even from the best program, even with the best pedigree you could ask for, the retina end of it 20 something years ago was really weak compared to what we were used to in residency. I before I went to my fellowship, I spent 5-6 months with John Chen as a senior resident, drawing detachments, doing cases with him, and then went to a fellowship, and it's a 5-year residency, 1-year internship, 4 years ophthalmology. The 4th year was 5-6 months of retina, as I recall, and then the letters and the recommendations and off to a fellowship. So there's a maturity factor of being ready to do it. Now, how do you make up the ground when you haven't had that kind of training? You have to throw yourself even more into it. And I think we've, made that clear. There's nothing else that Flavio and many of the fellows that come to me have done other than devote themselves to this. So, on the bus reading papers, sitting there with a B scan, trying to figure out a way to look at ultrasounds in detachments for days and nights, and leaving him in the clinic
before the OCT.
But yeah, how do you determine the success rate of pneumatic retinopexy with the B scan? Hyaloid is attached, 44% success versus something like that. That ended up becoming, your magnum opus, we say, major work. But you have to have the staff who are willing to let you do the work, see the patients in that way, but they'll do it for the guy who's showing that kind of above the not average. Average isn't good enough. You're just gonna, hear that over and over because you don't produce Rezendes and Khalid Saptis and André Maias if they're just, today's my day off. I was in the OR last night. That's great. I understand it's tiring. I mean, tell me something I don't know. I've been doing it for 28 years, day and night. It's not heroic. It's not bragging. It's devotion. That's the environment I'm in gives me limited resources. And if somebody comes in with a detachment, I'm not going to let them lose. I just won't let them lose. That's to the best of my abilities. Obviously, certain circumstances make us lose even in the best of efforts and wishes. So Flavio learned better than how to use an indirect. And I mean, one time we did a retinectomy with the indirect. Remember that? We did a case where you wanted to see if you could put an indirect in during a vitrectomy because there was just one little band of traction. I'm bringing it back, aren't I? And, with the vitrector and an indirect, just to cut one little clock hour of retina. That's how good he got with the indirect, right? So I think that the environment of North America, and people seek out Canada, even those from the US, is because there's less of a range of experience. So if you take the West Coast, Vancouver, Calgary, Edmonton, Even Manitoba is starting with a fellowship. Ontario, Toronto has 2 programs, Ottawa, Montreal. No one's walking out without doing a lot. And a lot can be a ridiculous amount if you show that you're ready early. That doesn't mean that you're proficient in peeling ILM right away. Not at all. I'd rather take somebody fresh, not quite that fresh, Flav, but fresh, and mold them than undo a stubborn person's way of thinking. And I'd rather that stubborn person, like somebody molded later on, tells me I don't do anything the same way anymore. That's like, I would say, the equivalent of raising your child. You want them to be a certain way for a certain amount of time till they show that they have all the autonomy, intelligence, and the self-responsibility to surpass you. That is the goal of being a fellowship mentor, is to build someone who's capable of surpassing you and watching them and helping them make that happen. And that's the greatest accomplishment that I've in my life. That's what I've done. I hope I can be nearly as good in raising my kids as I have been in raising, my sons and daughters who have trained through me in the fellowship. I don't, these aren't words, I mean it. I really think that's what I give back to medicine, is that while I'm sitting doing a guy who from Tanzania today, I just realized, who was traumatized, detached, synechiac, cataract, phaco, iris hooks, lensectomy wasn't much. He was a young guy, peripheral shave, drainage, buckle in a trauma setting. That the guy that I'm teaching this to will one day do this somewhere else, and that my communication of when not, and sometimes in a rough way, because it's got to be right. This person they're getting a fellow operating on their only left eye, so I have the right to tell that fellow, no, shave more here, do more this, laser here. It's not personal. It's your hands are doing what my brain wants you to do, and when your brain does it on its own, fantastic, we all win. But until then, get there. And it's by repetition that fellow after fellow will say, and I just got an email this morning. Can I permission to read it to you? It's from a recent graduate. It's funny. I thought it would be perfect for tonight. Fidan is a fellow who graduated. She went through a fellowship with me during COVID. I mean, such devotion. She would do the COVID swabs, get the patients into the OR herself, like incredibly disciplined. And so she was watching from Dubai Flow Retina live. So they were piping this into a meeting locally in Dubai. And I get an email from her saying, I'm watching Khalid Sabti, former McGill fellow, who is doing this trocar placement, very posterior, extracting subretinal bands. And she wrote, why didn't you teach me that in fellowship? I'm like, okay, well, COVID slowed us down a little. I didn't have time for those cases, Anyway, I connected her to Sabti because it is a brotherhood or a sisterhood. I connected her to Sabti. And she wrote this email that came to me 6:00 this morning. Dear Dr. Sabti, she copies me an email. Thank you for a fantastic case and surgery, and to show some new skills that I'm keen to try in the next suitable case. I was a fellow of Dr. Kapusta not long ago, 2 years into grad, and sadly for me, likely he is smiling reading these words. His words still echo in my mind while I'm peeling, draining, suturing, giving my fellows a hard time.
Wow.
I'm sure there are many negative comments along the way, but progress only happens when the most innovative of minds push the frontiers so that common folk like me can be a cheerlead from the sidelines and take credit that they graduated from the same place. That just happened to be this morning.
Wow.
So she's teaching fellows now in Liverpool, and I would like for her to go to Kuwait, work with a little bit with, and Flavio, you've been so involved in this, not just in Brazil, but around the world, that you meet these people and you connect them, and so on. But the devotion that she had has made her leave fellowship and become a fellowship mentor same year. You can't imagine how hard that is. It's easier to just go into practice, kind of feel your way around, get to know, I'm doing this, I'm doing that a few years. Then you're afraid to have someone else touch the eye because now you know how to make it work and you figure your own. But to go into fellowship teaching mode in the United Kingdom right out of fellowship, it speaks volumes about this individual. And it's the result of being ready to take on this fellowship. So I'll delve into that a little bit. Being ready is different. If you've done a 4-year residency and or some work before a fellowship, you come that much more seasoned, ready to learn more. You're more prepared to hear it, to absorb it, to be criticized. If you're someone who shies away from criticism, it's a much slower learning curve. You're actually making it harder for yourself in the long run. And I'm not talking about being someone who's looking to pick on people. I'm looking to build people, but you build by a little bit of joking, a little bit of sarcasm, and a lot of pushing. So you push physical extremes, mental extremes of what people can do. I've seen exhaustion. I've seen lockers with protein shakes and powders like Ensure. Do you know what Ensure is, you guys? Your cast, you know what that drug, that protein, it's what you feed old people who are protein wasting because of malnutrition. Do you guys have that product in Brazil? No?
I don't
know.
No.
So he's laughing because at one point during Flavio's fellowship, we were doing so many days and nights that he didn't have time to eat, that he opened his locker to put on his scrubs. And there was a case of Ensure in there just to
Whey protein.
just to eat enough, just to get the calories in between cases. And we did.
My body was wasted.
He was wasting. And he needed protein supplementation. TPN was an option, but it might have slowed the turnover in the room. So we let him go and get his protein or the Ensure shakes. Those were the days where we did literally many times, as he alluded to, cases that came overnight, slept an hour in the conference room, and then did a full office, and then maybe cases the next day. And I'll relay a story. I know I'm going on tangents, but I think they're helpful, I hope. I remember, Flavio, when you moved back to Brazil, and for the years that you were in practice there, and I don't remember the specifics of where you were, but I remember you calling me. And, among the many times you've overthanked me already, but this one really left me with a huge smile for a long time after the call. You were working in Rio, but were expected to help do cases in another city, in another state. And something went wrong with flights. You were supposed to give lectures. You're supposed to have a bunch of ophthalmologists, retina specialists in the room. And essentially, the crux of it was you barely got to eat. You never made it to the hotel. You went right from the flight to an OR. You slept barely anything on the flight, and you ended up operating as a visiting surgeon, but with a crowd in a room looking to be taught by you that day. And as you flew back to Rio, you were kind enough to call me and say, I never would have had the physical or mental ability to do this if I hadn't done it so many times. There's just no way. And I think that if you think about, I'm not a runner, but if you think about, you can't run a marathon, and you know this now, you can't run a marathon if you've never run 3K or 5K. You just can't. It's beyond you. It's beyond what you think you can do. And it's not to make somebody a marathon surgeon, but this generation of medical students and residents, for certain in North America, that are actually going on strike in Quebec next month. I don't know if you know, the residents are going on strike because they don't have a certain amount of time off after they've done a certain number of hours of a shift, which there's merit to it. It's reasonable. But when they go into their own practices and they're in retina or obstetrics and they have to work all night, but then there's cases the next day, what's going to happen? You still have to be accurate, exhausted and accurate, because you owe it to those patients. So this is the kind of discipline that I live by, and it's what I impart to people who train with me. I think it's severe compared to some situations, even in Canada. But I do think that the volume across the country that I was mentioning is intense. You need to be ready if you wish to come up here. I mean, we welcome applications to our center, and I'm sure there's other centers that'll be very interested. I think that you need to be mature enough and ready to make this commitment. And if I can add one more thing before I'm happy to take questions, but I'll tell you another person who's finished their training in Montreal, and actually at the University of Montreal, not at McGill. So with Flavio at his institution and at the sister institution, it's Bruno Ferreira, right?
Right.
So let me give you an example, and this is meant to be a compliment to her and certainly not a criticism. We met Bruna.
She's part of the FIER program.
Perfect. Well, I saw her at also in Montreal,
right,
in the this past summer. So this is somebody who did exceptionally well in your fellowship and has gone on to be very, very capable retina specialist. But she came to interview with us 1 year younger than when she was ready to work with you. And it showed. It was evident to all of us that this is someone who's talented, who's done well, but maybe doesn't quite understand what they're about to get into. Maybe she did, but when you're interviewing 15, 16 people in a row, and some people have done this, that, a PhD, etc., they strike you as far more ready, far more mature. So doesn't discount the fact that in the end, she did, I believe, an extra year of training or medical retina or research. Flavio would know the details more. She went on to do the fellowship with you. We ended up getting somebody else. That guy was good, but average. Your person was, I remember having, drinks with you, and she was somebody who could be incredibly relied upon, but she could be when she was ready.
Right.
And I think the message is clear. This is an opportunity to make yourself more than more than you are. Whatever you have in you, there's more. The question is, do you want to be a 5K runner or marathon runner? There's a big difference between them. Do you want to be somebody who's known in your country? For the research capacities that come out, that's a different kind of a position. The clinical surgical end of it is very much great opportunities in the Canadian training centers, McGill, University of Montreal, and others. And I think that if you're thinking about it as graduates of programs, residency programs, but even fellowships in Brazil, you're just going to make yourself into, a star. It takes a big investment to become that. And I would add that it's the hardest thing to do, because as you finish medical school and then a residency and a fellowship, we are worn down by those exams and what's expected. It is very, the most important stage of medical training, unfortunately, comes in the last of the moments, as you're the oldest that you ever will have been. You're not 22 years old in medical school. You're, late 20s, 30s. And I've people who've come from South Africa, they're 35, 36, 37 years old, starting a fellowship because their training programs are so long. But it's the time that you have to devote the most energy when perhaps you have the least. But if your mindset is, okay, what am I going to do for the rest of my life? I'm going to do retina. So biology 200 doesn't matter.
Right.
The neuro, obviously, it still matters to be a good ophthalmologist. You need to know general ophthalmology, but you need to give everything you have on the last lap. And the last lap is that fellowship.
So Kapusta, so what would be your message for young Brazilians or South Americans, whoever, they finish their residency in Brazil. Let's say in Brazil it's 3-year program, and they have this dream about going to North America, okay, for fellowship. What do you recommend them to do? Because they think, okay, this is like something unachievable. I'm, like you mentioned, when I got to you, I didn't even know how to use the indirect. So there's a huge gap from many programs across the country. We have top guys in Brazil in Retina. They're the top, like, anywhere in the world.
Yep.
The majority, this is not the reality.
Right. That's the difference with Canada, right? Like,
yes,
the top 30 people who do this,
right,
not such a huge difference. I mean, we'll send the more interesting endoscopic cases to Flavio because he has an expertise in that. But, the other cases, you're not going to look at one person and go, what? There's no what. Everybody can do it because they've gone through a process. That recommendation or what would it take to do it? I currently have a fellow who's having a rough time. Not from Brazil. Did 2 residencies. The last of which was in the United States, in Pennsylvania. And still, day one, the first summer in fellowship, watching the surgery, looked at me, and I was like, oh my God, I had no idea retina was so complicated. So that doesn't, you could do 3 years and start watching a lot of surgery and understand this is what is done. Doesn't mean that you're about to do it yet as a resident. Or you can do 2 residencies and still not be totally prepared mentally. So the timeline is important because to each of us, if I look at the 4 people, looking very comfortable sitting and doing this right now, any one of you who's done, I presume, 3 years of residency minimum, right?
Yeah.
Okay. And what if I told you you've done that 3rd year and the 4th year, you're going to do electives in surgery and read? You couldn't be anything other than even better.
Yeah.
So all of our programs are 4 years plus an internship, right? So that 4th year is a big difference because you're the most mature. And that's when you have to study for these exams, which are very nerve-wracking to the residents. And they ask each other a ton of questions. So the knowledge curves just climb. And the seriousness of the individuals climbs as they approach a process of examinations, and they're far more ready in that way. So time, the 1st and 2nd year, you're kind of just trying to figure out what ophthalmology is. Then it's a lot of, anterior segment surgery, typically, maybe some other procedures. But the seasoning of any capable person is best as the latter years. So I think that if somebody is really interested in coming, if they've done anything fellowship wise in Brazil, even as an introduction, it puts them in a great situation because, it's almost not necessary to state, I've done 200, I don't care. But at least I know, that you love it. You're prepared to go through the rigors of the training for it. It's not a surprise that it's going to be a little bit more intense or a lot more intense than the rest of ophthalmology. And, perhaps spark an interest in something in research where you could continue to do it, not just in your home country, but also carry that project into the next place. That's, it's maybe a piece that completes a fellowship is that you're not just learning the clinical surgical, you're investigating something. Maybe it's a technique, maybe it's a diagnostic tool, maybe it's something more in the lab, but something that makes you inspired. And it's hard. It's hard to work around the hours and do that, but it makes for a more complete 2 years. And 2 years, intense 2 years after after residency in the right individual, after an introductory year, I think would put you in a good standing to come. And I think that it also, like, and I think you do this very well with this program. People come up and watch you in the OR, right, Flavio?
Yep.
You know, take a month, take a few weeks, be a guest. You know, I told you again, I'll circle back. Doheny had so many Brazilians visiting.
Yeah.
All the time, Brazilians are in the room. You know, they came not to get the clinical exposure because they didn't have the licensure or whatever was required in California. But Steve Ryan and Larry Chong made it quite welcome that they all settled. They all had apartments in the same street in Pasadena, and they did you know, Rogério Costa. Like, that's where I know him from. He was an observer, and then he did research there.
No, I didn't know that.
Yeah, sure. That's Thelma Florencio in Recife. She was there at that time. It's a long time ago, but it's a relationship with an institution that invites you to smell what it would be like. And I think that there's room for that. Of course, it's devotion of time, energy, money from your lives, but it's a major commitment that you would be making. I think it deserves a biopsy, right? Like, get an idea of what you're getting in for.
Right.
And I want to ask a question. And I mean, you saw a lot of changes over the years. I mean, your fellows from 20 years ago are not probably the same profile as you have now.
Yeah.
And I mean, retina surgery changed a lot. We have more machines. We have many diseases that we didn't treat it before. And how do you think we should prepare ourselves? And how do you think we can get advantages from all these changes? I mean, we can, as you said, we can watch flow retina from other places that it was not possible 10 years ago.
Yeah.
How do you see all those changes and how they impact positively and negatively the fellow?
I think, you know, it's great to see meetings like Flow Retina and all these meetings. You're seeing the top of this, but it doesn't mean that there's not another 200 people, 400 people, 5,000 people could do exactly the same technique. There are people who are better at presenting it and whose career ambitions include being on such a stage, and they're great at it, and I give them credit. Sometimes those moments on the stage and the recommendations that you hear in those things are a little bit, in my opinion, testosterone filled. They're more aggressive than you would be on your mother. Okay, so I like to think of it, and that's reality. Like, you know, go to the American Academy. You have a podium of people. What would you do? Oh yeah, I would do this. I would do that. Yeah. Okay, now it's your mother. Are you still going to do it? And that's the way I operate. I do the exact same thing. I don't change one thing of what. And what does that mean? That means learn the bread and butter basics.
Mm-hmm.
You can watch Khalid Sapti put a trocar behind the, 20 millimeters back and pull out a subretinal band. And I mean, great. All the power to him. It's brilliant to offer somebody, the option of not having a retinotomy made. It makes us think that way. And he's been campaigning for this for a long time. And I've visited his facility, in Kuwait 4 times. Terrific. It's not for everyone, but you can't not know the basics. You can't not know how to take off a high load and how often you have to recognize that you missed it. You can't not be able to do a proper peripheral examination, shaving of vitreous to reduce the risk of redetachment. You can't go into practice and tolerate, 60%, 70% success rate with retinal detachment surgery. It's unacceptable. And that means you didn't get it right or you didn't learn it right. The guys who then take that further by saying, not only can I fix a retinal detachment, but I could fix it without putting a hole in the retina. Great. That is spectacular. But for the other 99% of the retina community, you should look at it as interesting, maybe one day something to consider, just like Fidan is curious about this technique that was demonstrated. But day in, day out, knowing the bread and butter, doing it repeatedly in your early years of practice, welcoming all the hard cases, not looking at surgery as a mechanism to earn money, because it'll happen anyway. Because you know what? If I do the easier cases, and I think Rezende is the best example of that, in our environment, I'm paid per case. If I do a case that takes me 20 minutes, 30 minutes, or 3 hours, it's the same thing. So which one are you going to go to after a while? You'll go to the easy one, because that's just, we're all human. We're not stupid. But if you do that, the hard ones are too hard very quickly. And you'll make it anyway. Just, Larry Chong gave me this as I finished my fellowship. It's a slippery slope when you start doing procedures to earn, that's all you're going to be. And you slide down that slope. He knew that I wasn't that kind of a person, but it was kind of his departing message to each of the fellows. Like, just do what you need to do. And at the end of the year, that's your salary. Okay. Don't look at a person as a procedure, as a financial reward and compensate this. We all need to eat. We all need to get places. We need to go on vacations, but devote yourself to doing the harder stuff. Sit there with scissors and forceps and a diabetic for as long as it takes, because that'll just make you better for the case that the vitrector, even though it's a better tool, that's what you're adding. It's a better tool. We talk about diabetic tractional retinal detachment. We didn't have the tools to take off all these membranes with the distal bevel tip cutting at 20,000 per minute. So now a lesser skilled surgeon could almost produce the exact same thing because the tool is better. You can get that close to the surface of the retina and you can shave off Menie's membranes and leave some of it, and it looks almost as good. But I would say, good, that's great. Now you have an easier way to do it most of the time. I still think you should put a chandelier and a scissor and a forceps and kill yourself till you're good at that, because one day that's the only way you're going to save somebody. So do it as the opening starting point, lifting with the membrane, looking for the plane, not getting it. Do it on easy cases that you think, for sure I can get this with the vitrector. Good for you. See if you can do it with a scissor and a forceps. And don't lift too much and don't pull and don't tear, because someday you're going to need both your hands to be able to do that. So don't let the technology undermine the skill of the hands, the coordination, and the judgment. Let it be the best adjunct you could have hoped for. A 27 gauge, distal tip, cutting at 30,000 on the new Unity. Wow. That's going to make us all able to give better vision to most diabetic patients. Fantastic. That doesn't mean each of you should know how to do it the other way at all. Lens techniques. Look, you get comfortable doing something. I would say doing something a million times. Each of us is going to have in our career after the fellowship. I didn't know how to peel an ILM in my fellowship. Nobody peeled ILM in my fellowship. I sat in the hall, Flavio, remember Theater 4 where you were trained? I was in the phone outside watching a fellow at the time, calling California, and Chong says to me, "Hey, dude, you know that cardio green stuff that we use for ICGs? Yeah. Spray some of it on a retina and take your smallest forceps and just peel the shit out of everything. It works." That's how I learned how to peel ILM.
Really?
One phone call. I know exactly where I was, like, cardio green. Like, oh yeah, it's true. Go downstairs, get a vial, spray it on the retina, take a forceps, which looked like a jaw, like was so huge. Then you have these tiny little, no, I don't like the isometric forceps. I like the ILM forceps. Are you kidding? I was using foreign body forceps. So I think you need to enjoy the developments of these tools.
Kapusta used to ask us to peel with the
left hand,
dominant hand.
Yeah, have to be able to do it with both hands. Still, to this day, some of the fellows feel that's stressful, so I give them a wellness day the next day. I'm joking, but I did a lot of things in the early days that some of it carried over. I used to make the fellow put the light pipe in, put the vitrector in, sit in the middle. You feel like you're in the middle. Does it feel okay? Move your hands up, down, right, left, X, Y, Z in motion. Now hold your hands there and don't move. And then do nothing. Do you remember this? Don't do anything. Now close your eyes.
Yeah. Flavio,
Close your
always
eyes.
tell
and
us about
stay there. Because you know when you're moving, and you need to know all these things. These things will make you challenging yourself with physical tasks inside an eye. Could be a yamani, could be peeling the ciliary body like some people do every week. Could be whatever. If you try to just steer away from those things that make it hard on you, there's the ceiling's a little lower of what you can achieve.
Mike, how much have you had to adjust to the new normal of our younger candidates? Please enlighten me.
I think that I've been blessed for the most part to have many people who came as very, very grateful for the opportunity from different places in different countries. From a guy who came to me, Jorge Sar from Chile. The guy was fantastic before he walked in the door. I learned some things from him. He could do stuff. I was like, what do you do? I walk in the room. I still have my nurse that was with me then. We imitate him whistling while he's peeling blood off the back surface of the lens. I'm like, what are you doing with the vitrector so close to the lens? He goes, well, how else would you get blood off of a lens? I've done this in trauma in Chile. I'm like, oh, okay. Like, it was like, so this guy was that ready. Nice. Why did he come? Because he wanted to be able to say, I did a formal fellowship for 2 years in Canada and go back and be even better recognized in the city. He had the skills already. So those kinds of people are a privilege and a pleasure, but still pushed the patient in another room, never acted like a prince, did all his work. In fact, I trained someone who's a prince. Two guys from the Middle East who are literally descendants of royalty. They push the stretcher in and out of the room. They, help patients on and off of it. They never behaved like they deserved. And literally, I've gone to visit and you realize, oh my God, oh my goodness, I had no idea, right? Like, okay.
That's great.
This generation, I don't think that the best among them are any different. I just think the average the median is very wide of that's enough. I don't need to do more. I don't want those who want to be great will continue to do so in this time. And tools, technology will help, but those who have, you know what, Flavio, my weakness. So weakness, they'll look for an excuse and an explanation. And in some cases, their threshold for getting super frustrated is just too low. They don't understand that the punishment makes them stronger, right? It's taken so personally. And I'll even say, it's not personal. I say the exact same thing 25 times in a row. That's, and then I'll give examples. Like, look at how well these people have done. Right. It's not intended to damage people, I repeat, but the current graduates in medical training, the current residents expect less from themselves, protect themselves more lifestyle wise, which, let's face it, ophthalmology is a lifestyle profession, except retina.
Yeah.
It's not. It is medical retina. It's fantastic. They do a lot. They evaluate, they look at the scans, they inject, they do really well. And yes, their day may be a little longer but it ends. Nobody turns to them and goes, hey, Flav, I got a guy I did an injection on. out of my X number of injections yesterday, and now he's complaining of this and that, and I'm going to the cottage skiing or surfing or whatever. You fix that now. It's a really nice guy, right? It always goes with, it's a really nice guy. Okay.
Yeah.
So you have to have the discipline to say, okay, ready to do that in bad view, and give the explanation to the person who got less of an explanation. It's surgical retina is being a fireman. Sometimes you just have to be available, and it doesn't matter if it wakes you up or, maybe my environment's a little bit harsh, but I still think the mentality should be of a fireman. And the other, I've used pilot.
This in
pilot
English sounds like fire, right?
Yeah, exactly. That's true. I've used this a lot in training fellows. Like I'll say, they're a little groggy. We had come in doing a case and we've worked a lot, whatever. And they're, is it really safe to do this case, Dr. Kapusta? Because, we did this and we did that and we're tired and the team isn't this and that. And I go, if you were in the military and I gave you as the general the command to walk through that minefield, would you be a little sleepy or would you be very vigilant? Because this is no time to die. Wake up, do it right, get across the minefield, and then we'll talk about breakfast. Sounds familiar, huh?
Yeah. Because, the reason why I asked this is because, there's some data saying that, companies are having hard time to find CEOs because people, they don't have the drive anymore to get there, because when you get there, there's too many headaches and there's
a lot of headaches.
You're going for, a
in politics,
salary, but a better lifestyle, so that's my point. So I think, and, we're, sometimes, programs in North America are having a harder time to match people.
Yes.
Because
there's a recent era of that. Yeah. Well, I'll tell you, I'm going to be specific here, and we'll talk about surgical retina. Surgical retina is having a harder time matching now in North America, and even, up in Canada. It's been more bizarre than ever. But I think it relates to economics, and the economics dictates what I was talking about before with medical retina. If the people are interested in the economics exclusively, and don't get me wrong, I love earning money, but the word earn is earn. I earn it. I work for it, and I don't take anything from anyone. If you decided to back up a truck of money and that sound of the truck beep, 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 backing up to my house and unload money, I would take it, but I'm not going to hurt a person to take it. Now, there are many who go into ophthalmology because it's clear, it's a better earning capacity than most fields or many fields in medicine, and that's fine. There are people who do cataract extractions on a lot of eyes every day that they wouldn't do it if it was their family member. It's just, there's no difference, if you take $1 or $1,000, or if you take it to do an act that's unclean, either way, you're a whore, right? Like, it doesn't matter how much. You're still that lower level of person. You go into medicine to help people. You like eyes? Fantastic. You like ophthalmology? Beautiful. You like retina? Spectacular. The dynamics of the fellowships have changed because so many graduates gravitate to phaco injection. And the financial world that have bought over a lot of these clinics, and even the senior staff of these clinics, have realized, because, and this is particularly in the United States, the compensation associated with injections is so great that there's no motivation when money is the topic, not interest. When money is the topic, you can wear a beautiful shirt, nice little collared pattern inside, nice jacket, do some injections, don't break a sweat, leave the clinic at 5 o'clock, have dinner with your wife or significant other. It's a really pretty life. They're not motivated to do the surgery because it doesn't pay as well anymore in the US. The interest in retina fellowships in my day and I had to fight against the competition with this because it wasn't the story in Canada. In my day, the retina fellowships retina was among the most lucrative things surgically in the US. So I didn't know this even until I got there. I was like, oh my God, I didn't realize why the competition to get the fellowships was so stiff. Now it is only for now shifted. And if I can answer your question about how would I guide the younger generation, don't park yourself on a procedure and think it's going to last forever. Don't know one thing. I don't care if it's phaco, injections, you got a long career. Something comes out, a pill, a pellet, a this, a drop, some other technique, and you're now obsolete. So my father taught me this. My father's now retired. He's the first, he's the first board certified rheumatologist in Canada. And, talk about hard medicine. Like they're really, the referral of the most complex cases come to rheumatology for the diagnosis. So he used to say to me when I was in medical school, and I have said this to many generations afterwards, if you strive to know the most, then handling the hardest things will be normal for you. If you shy away from it, then your skill set will continue to diminish until everything becomes daunting, challenging, scary, and refer it out. Get rid of that. That's, I'm not sure what's under that red. That looks funny. Call this guy, call that one. And there's general doctors who are like that. And there's ophthalmologists who are like that. They are excellent at a procedure or two. And when it gets a little ugly, they're gone. Now you have the ability to do anything you want. Your brains are pluripotential cells. You could be whatever you want. You could be an average doctor, an average ophthalmologist, or you could climb to as high as you can and hold it there so that every day when you see patients, it's drink a coffee, order lunch. There's nothing complex about it, even though to someone else, their worst nightmare is one of 20 of your patients that day. They're like, oh my God, there's a this, that. Yeah, okay, send it. Choroidal hemorrhage, Flav. Okay, I'll put a trocar through that, no problem. Right? It becomes your bread and butter, becomes easy. Learn the basics, strive to know the diseases, learn your uveitis, learn the neuro, and learn, whatever you wish to learn in retina. But Flav, to come back to your question, the current, underline, bold, italic, the current atmosphere in North America is medical retina and injections, and it's not even from the doctor's injection. It's from the rebates on the drugs coming back to the physicians' clinics. That's why there's no way you can compete with that. So that's not a Canadian phenomenon, but it's a North American phenomenon that they want to train people to inject. Venture capital is buying up all these clinics so that they can have the pharmacy compensation or the company compensation to the clinics, which far exceeds anything you could do in an OR. So you see senior partners giving surgical cases to junior partners and working 3 days a week because they'd rather hire people to do this kind of, repeatable work. It's a different atmosphere. It's terrible. It will be short-lived. It won't be forever. Just be what you want to be in retina and ignore that mess.
Dr.
Guys?
Kapusta, may I ask you a question?
Sure.
I'd like to know what makes a good teacher. What have you learned over these 28 years teaching others, and how far can you go? Have you left anyone and say, no, this guy won't do it?
Yeah.
What makes
So I'm going to, you gave me I didn't really think right away what my answer would be, but I'm going to give you the one who we dismissed. We dismissed somebody from the fellowship, and I'll tell you the example of what happened. Person who all the right letters and everything seemed good, trained abroad and then did a year in a Canadian institution, looked to have all the criteria, came in and no hunger to learn. And something as basic as the stages of a macular hole. So we get to the microscope, got a patient with a macular hole. This individual says, can I start the case? And I go, absolutely. Tell me what the stages of macular hole are before you scrub. And the person couldn't give me the answer. And I was like, don't you think this patient deserves for you to do this surgery, for you to have the privilege of operating in their eye, that the doctor that's operating on them knows that there's stages to macular holes and that stages are treated and evaluated and maybe operated, maybe not operated differently? Don't you think that the responsibility means that you need to have the core knowledge before you do the physical task? Okay, Dr. Kapusta, thank you. I said, so learn that and, we'll come back to this. Now, I never forget anything. So the next week, sure enough, there's a macular hole. And I say, why don't you sit down at the scope? We'll set up your PD. Get started on this case. I've already put the block, I've put the drapes, and then person sits down to operate, and I say, oh, just before you start, literally had the first trocar in the hand, just before you start, what are the stages of macular hole? And then, oh, you know what? I didn't read it. I didn't look at. I said, really? Yeah, look at him. Okay, he's dying because really, we talked about it in the. Remember, we talked about it, right? Remember, I said go read it before the next one, and sure enough, you knew last night. You saw the list for today, and you didn't think, oh my God, I better know this. He's going to get me on this. And the answer from this student was, where I plan to practice, they're not going to ask me questions like what are the stages of macular holes. I just need to know how to fix eyes. And my answer was, you're never going to have my autograph on your diploma. You're done. Either you're going to be great at this, knowledgeable in it, or not. Now, it wasn't an immediate dismissal, but she was done from operating that day. And within a month, the others said the same kind of thing. It was, you have to be prepared to do it all. Does that make a great teacher? No. It shows you as a leader and as a teacher that I am serious, that I feel that I need to have continued knowledge. I can't just sit back on what I learned back in California. I have to continue to read, continue to go to meetings, continue to learn. That's part of the responsibility. If I'm operating 2024, 2025, I should be giving them what I was 5 years into practice, which was really young, smart, hot, knowledgeable, coordinated. I have to be exactly that still today. That's a responsibility. So I offer to my students an example of intensity, of vigilance. Flavio say great surgeon, and I appreciate it. I think that at some stage, I'm not going to be a pro athlete. I'm not that, but I am very good inside an eye. But I'm very good because I have vigilance. I don't drop the ball. I don't defocus. I don't lose my concentration all day, all night, all the time. That's the skill. It's not that I'm more coordinated than somebody else. And so my students learn that.
Yeah, I think the one thing the Kapusta is really good is putting inside your mind, your reflexes, what's to be avoided. And when you learn what's to be avoided, it gives you a sense of focus and control of the eye, which was much less control when I was training with him, because like chokers, there was no choker. Everything was like, the eye was outside control. Nowadays is way more under control. And so when these, the behavior that you have to understand how the eye works and what's to be avoided, I think it's just like, it's not something that I am as good as you are teaching my fellows, because we have like 10 other guys. You
Yeah.
know?
You know,
And so there's benefits to have, like, to learn different ways of doing it, but then you don't get that much time with each one of us.
right.
So it dilutes what you come out with, you
Right.
know.
Yeah, that's an interesting message, actually. I remember looking as I finished training and going to different places in the US and seeing, you know, what the experience would have been elsewhere and who's the best. And, you know, I visited Will's, and that's many, many years ago. And they were sitting now, I don't know how many surgeons, but at the time there were 9 surgeons. I thought, oh my God, 9 surgeons you need, and how this one puts this and how this one, you know, half the battle would be just knowing that you're satisfying those people's needs. You must come in with a notebook. Like, how do they like things done? How do they like the head? How do they like this? How do they So that's a challenge. And yet, if you're really ready for it, you can get the little bits that are subtly different between different surgeons.
Right.
But there's, on the opposite end of it, what Dr. Rezende is saying is, if somebody knows literally every single move that you make, and you know every move they make, you can get some of it accomplished perhaps more completely quickly. So I remember when Chow left, Flav had 18 months straight with me. 18 months straight. And then went on to do it differently in the different places, and even in the same city now. But 18 months straight, it's a very unusual situation now. It was, Dr. Chow was with us, but then he moved sort of, I think, yeah, he moved to Chicago at the time, but 6 months in. I think you can get a lot, there's less, you know, avoidance of pain. Pain avoidance is what I learned, because we had open sclerotomies, fluid everywhere, bottle empty, blood here, cut rates of 600 when 650 came out, and then 800, it was like, oh my goodness. So that, you know, 20,000 levels the playing field.
Mm.
You don't need to be like seeing the trouble happening before it happens in a less controlled environment.
But
it's
then
great
their
to have those
reaction is
skills.
much lower or absent, because they don't get used to seeing the problem. So it's like a cataract surgery, you know. They're, you know, phaco is a great surgery 99% of the time. That 1%,
You gotta, but
beat.
that 1%, when I teach residents too, I teach them, don't pray, don't hope, don't this, maybe it's cortex. No, it's vitreous. Maybe the bag. Don't say, oh man, I think it's a no. Shut up. Get it out now. Take the time. Put more time into doing a vitrectomy now. Don't pray, hope, right? Like, it doesn't get you anywhere. The first person who recognizes the problem is the one who can best bring the dominoes back on track. So you have to be looking for problems.
Because my challenge in the FIER program is that I get people were trained by someone else.
Mm-hmm.
And then I'm there like to fine tune. And then sometimes they have like the proper tools that I can work with. And other times is like, it's so, you know, like open. Like when I start talking, it's like,
and some people won't listen,
right,
because they got used to something. So, Fidan, who's I quoted from the email from this morning, you know, when she started, you know, the cut, you can have it on whatever settings you wish on the machine, you know, the pedal control. But essentially, for purpose of discussion, let's presume that for us, the pedal all the way down is the most vacuum. And so she starts, you know, you're so worried about your hands, and the microscope pedal was 1 foot, that the only thing she wouldn't hold her foot off. She just, at least she didn't have to worry about 1 foot. She was at 550 from the get-go. Didn't matter if she was near the lens, near the peripheral retina, anywhere. So she's from, you know, the United Kingdom. So I said, hey, Nigel. Her name's Fidan. She goes, excuse me? I go, hey, Nigel. She goes, who's Nigel? I go, Nigel Mansfield, the Formula One driver who kept his foot on the pedal the whole way through the turn. I go, do you have the right accent?
Mansell.
He's off. And she says to me, Dr. Kapusta, why don't you call me Lewis? And I said, you're no Lewis. Don't even mention Lewis. Don't even think in your first year of fellowship that you mention Lewis in the same word as you in an OR. Don't even talk about that. Nigel, maybe. At best.
Hilarious.
So my current fellow is from Mexico. And I say, hey man, you're trash, just like Chico. Give you the right tools, but you're still finding a way to get up. So you got to be entertaining as a teacher. You got to catch their attention. You got to make it stick because it's coming through different paths in their mind. Bringing a sense of humor to it makes them know that even though you're criticizing with intent to entertain yourself. I mean, I love doing this. I just have fun. I have fun. I have fun watching it develop. Like take somebody from nowhere into practice, and somebody who contributes to their society. Fantastic.
Yeah. It's like it's the name. You become so proud. These guys there. I mean, there's some badasses there sitting on the chairs there, man. Honestly,
good.
It's cool. It's really cool. Anything else, guys?
No.
My fine.
So thank you, Dr. Kapusta.
My pleasure. My
Thank
pleasure.
you.
It's an honor. I know that
Amazing.
that it's fun. I didn't realize, Flavio, that you were going to be also with us on this. I assumed that I was just going to meet the crew. So
Nice.
it made it perhaps even more fun for you guys.
Yeah.
I can only imagine what was being whispered in Portuguese. This guy says the same thing over and over. But you were respectful enough to say it that I didn't hear it. You see, that's part of the elegance of being in this stage.
No.
It's a privilege. I hope to meet you guys in person and
Awesome, man.
here in Montreal or meetings
Yeah.
anywhere. Good luck with the careers.
Thank
Keep
you.
well.
Thank you,
Great,
Dr.
thank you very
Kapusta.
much.
Thank you.
Very
Take
inspiring.
care. Love. Keep well,
Thanks,
man.
guys.
Bye-bye.
Bye.